So we should get a normal genes from our parents. We should have like 2 normal beta gene from parents and 4 normal alpha genes from the parents at the same time. If we had both normal, we will be able to produce a normal hemoglobin. But this is not the case in thalassemia.
So we tried to kind of all these tests.
I retired, I mean, obviously, but thankfully,
All right, yet another Tuesday, and we are back with Tell Me Why. With me in the studio is Dr. Maryam Darwish, MD, Hematology Oncology Center in Sheikh Khalifa Specialty Hospital. Dr. Maryam, how are you?
I'm good. How about you?
All good, all good. Love your smile, love your energy. We had
you.
such a pleasant conversation before we started rolling, and I can't wait for you to share your knowledge about this topic that we're going to talk about, which is basically thalassemia. And I think it's an interesting topic, and I think it is one that must be addressed because it has become more and more prevalent in our society. But we're not going to get into those details yet. We're going to start very basic. Tell us first, what is thalassemia and what are the different types of thalassemia?
So before I start with thalassemia, I love to explain about the blood a little bit. So like the basic information so people can understand what is our disease entity coming from.
Yes, by all means.
So our blood actually had 3 major components, like the white blood cells, the hemoglobin, or what we call red blood cells, as well as the platelet. And each component of this has a specific function. So let's say the white blood cells mainly fighting for bacterial infection, viral infection, allergy, like that. The platelet to stop the bleeding when it's happening. And the red blood cells have the hemoglobin that basically will carry the oxygen to the tissue and the organs. So when we talk about thalassemia, we are actually talking about those red blood cells. So the problem in thalassemia is basically a problem of the red blood cells, the hemoglobin in that red blood cells.
Right.
That's basically the thalassemia. So to define thalassemia, I would say thalassemia is an inherited blood disorders. Okay, that basically coming from the parents to the child. And we do have a different type of thalassemia. But before we go to that, let's talk a little bit about thalassemia. Like, what is the problem here? Mm-hmm. When I said it is the red blood cell disorder or there is a problem in the hemoglobin, I mentioned that the function of the red blood cell is to carry oxygen to the tissue.
Absolutely.
So if I'm having a problem in that red blood cell, the body cannot transmit the oxygen to the tissue or the organs. So that is thalassemia.
Okay.
And there is another disease, a lot of diseases like genetic problems in the hemoglobin or other that can make the same. But thalassemia is a very unique disease. Basically, that's it.
Okay.
So, and more things to add here is when they have like thalassemia or abnormality in the gene, the red cell, the lifespan is short. That's it. So they die quickly.
Okay.
Normally our red blood cell will stay for 120 days. But for those, it's not the case.
Okay.
It's short. So basically, they will have anemia.
Okay.
Okay.
Makes sense because it's in the hemoglobin.
Yes. So it's anemia, basically. So they cannot stay for long with that low hemoglobin level.
Right.
So we need to do something to help them because they will start to have anemia symptoms. Like they will feel fatigue, weak, not able to concentrate, they are pale, they cannot function, they cannot do their daily activities. So that's how is it basically.
Right.
It's a problem of the hemoglobin, but it is an inherited problem.
Okay.
Okay?
All right.
Yeah.
And now the different types of thalassemia.
So there is a lot of types, but to make it short and easy, there are 2 major ones. We call it alpha and beta thalassemia.
Okay.
Why we call it alpha and beta? Because it had been discovered many years ago in the Greece area.
Oh,
okay, so it's a Greek word. So alpha is an A in a Greek language, and beta is the B. So that's why they call it. And thalassemia, to be honest with you, is anemia of the Mediterranean Sea. This is the definition of the word itself.
Okay.
Yeah. So they call it alpha and beta. That's the 2 major ones. And to know more about the types, I would say basically because for us as a normal people, we should have a normal hemoglobin.
Okay.
So we should get a normal genes from our parents. We should have like 2 normal beta gene from parents and 4 normal alpha genes from the parents at the same time. If we had both normal, we will be able to produce a normal hemoglobin. But this is not the case in thalassemia.
Okay.
Okay?
Okay.
So alpha thalassemia, as I said, there are 4 genes, and beta thalassemia, there are 2 genes. Any defect of any of these will result in thalassemia. I want to explain it for you more, and if you would like to know
Please, yes.
the details of that. So as I mentioned earlier, this is the genes for alpha. And I put this line here basically to let you know that these 2 are from one of the parent,
Okay.
and the other one from the other parent. And this is the beta, one from maybe one of them and the other from the other parent. So that this is, if we have a normal, we will get a normal hemoglobin. If it's abnormal, we will get abnormal hemoglobin or thalassemia. Now, let's talk more about alpha. So if there is, I would say 2 genes, we got that from the father, and these 2 genes got it from the mother. If one of the genes are affected, that's an alpha thalassemia.
Okay.
Okay?
Okay.
If 2 of the genes, and it doesn't matter from which side, affected, that's an alpha thalassemia.
Okay.
If the 3 genes are affected, also that alpha thalassemia. And it depends on how many genes are affected, the symptoms will appear or not.
Okay.
So most of the patients who have only 1 gene abnormality, they are asymptomatic.
Okay.
There is no symptoms. Maybe
Okay.
sometimes you don't recognize that they are thalassaemic patient, and we call it them trait or a carrier for the disease,
Right.
and that's it. Also, for the 2 gene deletion, the same issues. It's not basically causing any problem, but it can explain for us why their hemoglobin is little bit lower than the normal people. And for the other one, if they have like a 3 gene deletions, they can manifest as a severe anemia sometimes.
Okay.
Okay? 4 gene deletion is the worst, and usually they die intrauterine, basically.
Okay.
But the advancement in the health development actually did turn that a little bit different now.
Okay.
Now, this is alpha thalassemia. If we will talk about beta thalassemia, if we have 1 gene deleted and given to the child, that will be a carrier.
Okay.
Only 1 gene. Let's say we have 2 parents, a mother and a father, and they give only, and both of them, let's say both of them are a carrier for the disease. So they can give only, let's say that they give both of them the good one.
Okay.
I will explain it more. This is, I will make a star here
Okay.
to say that this is the abnormal one. Okay?
So each parent has an abnormal
Let's say
one.
each parent have a 1 gene abnormal.
Okay.
Let's say it that way. And now we have a child. What are the possibilities to have a child with beta thalassemia? Because we do have 2 types, either a carrier, which should be fine, or a patient with a disease. And that's the problem. Here is the problem. So now we have this scenario. Let's say we have 2 carriers, and they will planning to get a baby. So the chance is, by genetic distribution, we are just talking about the chances here. So there is a chance to take this gene, which is an abnormal gene, with another one, which is an abnormal gene, isn't it?
Yes.
Okay. The other chance is to take 1 abnormal from here with a normal one.
Normal. Yes.
Let's do the other side, a normal beta gene with an abnormal one here.
Yes.
And the last one,
Normal and normal.
and normal. So this is the chances. So the chance for them to get a child with a disease is 25%. It's just a chance,
Okay.
okay? And a carrier is 50%.
Mm.
And a normal is 25%.
25%.
So that's how is it.
Amazing. I love that. Thank you so much for the
You're welcome.
for the explanation and you know, like the written form of it, because I think I wouldn't have understood it unless you did that, and I appreciate that, and I'm sure you do that with patients as well,
yeah, we
so
do
that they easily understand, you know, the chances, the risks, how this disease actually occurs in a person, you know, either through conception or genetics. So I guess my next question would be, if to follow up on the explanation that you just offered is, let's say both parents have given the child the thalassemia beta gene. And let's say the child now has thalassemia.
Yeah.
How does it affect the child? Like in the case of the parents, they could both be carriers, so they're asymptomatic, as you mentioned. So then how does it affect the child health-wise?
So
What do they experience? How do you catch it in a child?
okay, so there is a test we do it for the, and it's very simple test, and it's
Okay.
available everywhere.
Okay.
So they can do that test for the child. Before we go to the actually to for the testing, those parents can actually be examined when she's pregnant.
Oh, okay.
Yeah, there is a technique that they can examine the fetus, and they can know the genetic of the fetus when she is pregnant. So that's one of the tests they can do it.
Okay.
Let's say that she had the baby is born, and they want to investigate. Yeah, after a couple of months, like 6 to 1 year, they can do that test. And it will basically show for them that this patient or this child is a carrier, or it is a diseased, or it is a normal, because still there is a chance to have a
There is
normal
a chance,
child.
yes.
Yeah, so it's a blood test. They can do it. It's very simple, and it will basically answer their question. If the child is a disease, let's say, or having what we call beta thalassemia major, we call it major because it's 2 gene got affected. So if the child had that, he will go through the long journey of beta thalassemia major, which
Okay.
will never end.
Okay.
But we do have some, I would say, solutions early on. Like, for example, they can go for bone marrow transplantation.
Okay.
Yeah, so that's one of the options they can get earlier than later, especially in the pediatric age group. It's very effective.
Okay.
We most of the time, the successful rate, let's say, it's higher in childhood more than in adult.
Okay.
So that's one of the options. If they decide or they don't have the chance to do the bone marrow transplantation, the other option is to go for blood transfusion.
Okay.
And it's a chronic blood transfusion management.
Which they would have to do, obviously, for a lifetime.
Exactly.
For the bone marrow transplant, does it, I mean, I'm going to use this term, even though I don't agree, it doesn't cure it, right?
It do cure it.
It does?
Yeah, it does.
Oh, interesting.
Yeah.
Very
This is
interesting.
the only treatment option that can cure the disease
Wow.
if it was done earlier.
Okay. Earlier as in...
During the childhood.
Okay.
See, the moment we grow up, especially those patients, they will get multiple blood transfusions.
Right.
They will get multiple complications.
Right.
They will get a lot of iron overload. So the risk to do the bone marrow transplantation later on will be very high. Risky. We always say it's a risky procedure, so we don't recommend it. But some, they do give the chance for those people who want to.
Yes.
But it's a high risk. It's a very high risk. But in childhood, it's successful. It's a curative, especially if you do it in high qualified centers.
Amazing.
Yeah,
Okay, so
yeah.
we mentioned blood transfusion for long-term treatment
Yeah.
plans. What are other treatments for people with thalassemia?
So for thalassemia, they blood transfusion. But if I don't think we should just pass blood transfusion and leave it. We
Let's
should talk
go in
about
depth,
it.
yes.
Because this is what they are actually, most of them, what they are getting nowadays.
Okay.
The transfusion.
Yeah.
So everyone is different. Some of them, they will require blood transfusion, I would say, every 2 weeks. And some of them will require it every 3 weeks, some every 4 weeks. So everyone is different based on the hemoglobin level before transfusion.
Right. Okay.
So when we are actually giving them the blood transfusion, we are giving them a lot of iron
Okay.
because each unit have like 200 milligram of iron.
Wow. Okay.
So by giving them like a 2 unit once, I'm giving them 400. Some they will require 3 units at once. So I'm giving them like a 600 of iron. That's a lot.
Yes.
So the body cannot handle that. So what will happen in such cases, the iron start to precipitate in the organs.
Okay.
Okay, so it will go to the heart, it will go to the liver, it can go to the pancreas, it will go to the thyroid, and will cause a lot of problems. So those patients can suffer from diabetes if the iron went to the pancreas.
Right.
They can suffer from heart disease because the iron went to the heart. They can suffer from liver disease because the iron went to the liver. So it's a really long journey that have a lot of complication if it was not managed well from the beginning.
Absolutely.
So that was why I stopped here, because there is a treatment that we give for those patients. Like we give the blood, and at the same time we give a medication to get rid of that excess iron in the system.
To counter any other complication that could occur. Yes.
Yeah, exactly, from the iron that we created by giving them those red blood cells,
Right.
or that transfusion. So that's one of the treatment. We said bone marrow transplantation.
Yes.
We said blood transfusion with iron chelation therapy. We do have some medications now available to increase the red blood cells or stimulate the red blood cells. So we can, by doing that, we are actually decreasing the amount of a blood transfused for those patients.
Right.
And less complications.
Because the medicine is technically producing it naturally now. The medicine is helping the body produce those red blood cells
exactly.
naturally rather than being transfused.
Exactly.
Okay.
And you can imagine how much problems they can get from blood transfusion.
Yes.
You know, blood transfusion at the end is not safe.
Yes.
We know, we do our best as a healthcare to make it
Yes.
safe. But we cannot guarantee 100% that
Absolutely.
it is a clean with the risk of infections and everything, allergy, anything they can get from that.
Yeah.
So that also, going back to the treatment options, there is also one treatment like nowadays they can modify the gene. With the gene technology, they can modify the gene and they can actually enhance the normal gene instead of the abnormal one. So
that's while the woman is pregnant.
It's
as
actually
a
done
fetus?
outside.
Okay.
They sometimes take the blood of that patient, the thalassemic patient, they modify the gene and then they introduce it back to them.
Oh,
So that's a
interesting.
genetic
Okay.
modifier therapy. Also, we do have a lot of treatment under investigations now, some of them to increase the fetal hemoglobin, some to work on the iron metabolism in the system. We are hoping that a lot of medication will be available for those patients. Yeah.
Absolutely.
Yeah.
So I love that you mentioned that nothing is 100%. Nothing is guaranteed 100%, especially in the medical world, and we know that. I know that there are complications that can arise from like blood transfusions, but what other complications or challenges do these patients face in like their day-to-day lives? You did mention, fatigue and, they are not able to function as high as any other individual. But what are some other challenges they face?
Okay, so I actually divide the challenge to two parts.
Okay.
One based on the disease itself and the other one on the treatment itself.
Okay.
So if we look to the disease, as you mentioned now, the anemia symptoms is very challenging for them. It's really hard for them to function on a daily basis. It's really hard to come out from the work to get a blood transfusion every 2 weeks. It's really a challenge for that.
Yes.
From that they can face. The other problem I would say from the disease itself. Nowadays we don't see it, but still I do have a couple of patients. The features of the thalassemia, like. We do have patients now in the 40s and 50s. They are thalassemic patients, and they have some feature in their face because of the thalassemia.
Interesting.
Yes.
Like what? Do you have any examples?
I will tell you. So these patients with the long time not well managed in regard to thalassemia, the bone marrow is our factory, is the factory for producing the red blood cells. So that bone marrow trying to compensate, trying to produce RBCs, trying to produce the blood. So it start to be expanded. So you can see that in their face.
Okay.
So they have like the maxillofacial bone widening, they lost the nasal bridge, they have like a frontal pulsing. So if you see one case, you will know he's a thalassemia just by seeing one case.
Wow.
So these features will let people recognizing them because it's unique for them.
Wow, I did not know that.
Yeah,
that
if
it
you
could
Google it,
actually
you will
affect
find
your physical features.
Yes, it do. It actually did
Wow.
that.
Okay.
So that's one of the, I would say, challenges that they are facing in regard to the disease itself. But looking now to the management, we have a lot of challenges because it will be affected by the financial issues, the availability of the treatment, also would say availability of the blood. That's a challenge. So not we have to give these patients a fresh blood. We usually recommend for a fresh blood because, as I mentioned earlier, the lifespan for the RBC is 120 days. So I don't want to give them something old. We want to give them something fresh.
Yes.
Finding a donor is a challenge. And sometimes with the time, they can produce antibodies in their body that will reject the other blood, the donor blood. So we really need to match that blood with them, with their blood. So that's a challenge for them. Getting the medication that I spoke about it earlier, the iron chelator, to release or to remove the excess iron from the body, that's a challenge for some of them because financially they cannot afford it.
Absolutely.
So that's a part of the challenge that they face. Not only that, as I mentioned, going back forward, and a lot of investigation we do for them. We have to make sure that the iron did not go to the heart. We have to make sure that it's not going to the liver. Like really, there is a lot of challenges they are facing.
Absolutely. I just want to go back to that point of developing antibodies to certain blood transfusions. How do you deal with that? I mean,
that's the worst part. But
I can assume. I mean, if the body's already rejecting that blood that's being transfused and that was donated to them, how else can you help them?
So sometimes the lab try their best to find the most suitable one.
Okay.
With minimal side effect.
Okay.
With minimal. We cannot avoid it, but it's there. So sometimes they try to find the best donor. Let's say they find one time that donor is the best for this thalassemia. They will call him every time to donate.
Oh,
for that.
Amazing.
Yeah,
okay.
Yeah.
So that's good. At least there's a database and they can always go back to these donors.
Exactly.
And that is a big role that our society has to play as well. I mean, we should all, if you have the ability to donate blood whenever you can, and if you are fit to donate blood, I think it's a societal responsibility that
totally
we
agree.
all should practice.
Yeah.
Everyone. Okay, so we spoke about treatment plans and we spoke about patients and we spoke about thalassemia as a disease, but how prevalent is it here in the country and in the region as a whole?
Okay, so it's a very common.
Okay.
It's a very common disease.
You mentioned it's a Mediterranean,
Yes, it's a very common, and it's in the region. In the GCC, it's very common as well. So they said that like the prevalence of the disease in the pediatric up to 33%, and in the adult about 43%. But because that will give you an indication that it's really high. Because when we talk about, I'm not just talking about thalassemia major, we are talking about the trait. Okay. A lot of people are treated and they don't know.
They're carriers, but they just don't know.
Exactly. They don't know that they are carrying the disease. So the prevalence is really high. And we should not forget the role of the country.
Yes.
We should not. Launching the campaign about basically raising the awareness about the disease, doing the testing, and availability of the test is everywhere. So I think we should not ignore that part.
Yes.
Yeah.
I was just going to ask, I mean, what are some of the initiatives that the country does, to enhance that and to encourage people to get tested? And you just mentioned there are so many campaigns. The kit has been available. It's available now in all institutions, and that's crucial. Okay, how can I prevent it? Is there a way to prevent it?
The prevention is always by education. I always said that.
Educating
people about the disease. Doing I would say, not only educating everyone.
Yeah.
And when we said education, we mean a lot of way to educate people. This podcast is for education.
Yes.
This is one of the way we should do it. The campaign, raising the awareness, doing the screening before they get married.
Yes.
That's one of the very important part that we should actually talk about it, because in UAE, they started to test couples before marriage like in late 90s.
Yeah.
Late 90s, and then I think in 2008 it was mandatory to be done, the premarital screening for thalassemia and actually sickle cell disease. That's how it is, and I think that's one of the ways to prevent thalassemia by doing the screening and the premarital screening. Other way, we mentioned it earlier, if the couple got married, done,
right,
they can screen the baby by doing the intrauterine testing. That's one of the way. After born, they can also test for the baby, and they can find the way to go for bone marrow transplantation earlier on, or they can delay that. It gives them also an options for the treatment in the future. Yeah.
Yes, I absolutely love that, because I think when I got married back home, it was mandatory. I had to get tested for thalassemia, and I remember everyone was talking about it, and they did speak about the fact that you could be a carrier, you just don't know. There is a chance that it's passed down down to kids, you know, when you think about conceiving. So it is, we always need to think about medicine as a preventative measure rather than reactive. I don't need to wait until something happens for me to go and get screened or see a physician. I should do it constantly, as you said. I should go for screening. I should check on my health. But where does it start? It's always that chicken or the egg kind of concept. What if there was no one in my family that had it and I found out that I'm a carrier? Or maybe we just didn't know. I don't know, like, can someone get thalassemia without it being hereditary?
No. We do get a lot of cases in the hospital. Like, for example, I do the test. Let's give you a scenario. They come to me, with low hemoglobin.
Okay.
So I do everything for low hemoglobin. Everything is normal, so you have to think about thalassemia.
Okay.
And the moment we tell them you have thalassemia, they go, no, there is no one in my family. No, 100% there is someone. It's no way. There is no way there is no one in the family having thalassemia. So I call parents to be tested so we can prove for them. Sometimes we test 90 years old just to prove for the family that this is really inherited and it came from the father or the mother side.
Yes, absolutely.
Yeah.
Okay, my last question. I know you're a doctor and you have so much to do. What's your advice for people that may have been, tested for thalassemia and actually have it, and that might be worried or that might feel like it will be a challenge, a challenging, journey? What's your advice?
It is a challengeable for them.
Okay.
100%, especially if the couples are a carrier.
Okay.
Yeah, but if one of the couples are a carrier, that's the easy part.
Okay.
But both of them, it's a very challengeable. So we do discuss with them what we discussed today. We give them those options, and they have the choice at the end. We do get patients before going ahead for the marriage, just to do the counseling. And to be honest with you, some of them, they go for it, and some of them, they just,
They don't actually go through. Oh, wow.
After the discussion. So we have to discuss it with them. We have to counsel them. And we have to say the details, to be honest with you.
Yes.
It's a long journey. Yeah.
Yes.
Yeah.
Knowledge is key, as you mentioned. So I think that's one thing that we aim to do here at Tell Me Why is to spread that knowledge because... you start by educating the public, and then that's when the action is taken afterwards.
Yeah.
Dr. Maryam, thank you so much for your time.
You're welcome.
Is there anything else you'd like to add, before we
Actually,
leave
I
off?
would say for the audience that we can prevent thalassemia, but we cannot eradicate it. Just remember that. Yeah.
I love that. That's a tagline, guys. Amazing. Thank you, Dr. Maryam.
Thank you.